We'll be discussing a bill that is proposing some new legislation for regulation of your industry. It's called the Kenya Drug Authority Bill.
Correct.
But before that, the day's proverb. City has been giving us proverbs from Nigeria this week, and he has been teaching us pidgin.
Been teaching us something.
That I think is more accurate. It is something akin to pigeon. It may not necessarily be a very fair representation of pigeon, but at least the attempt is there.
It's Pigeon City.
Right. Here goes. No matter how tall okra they grow, no go tall pass owner. Hey, yeah.
Okay.
Yeah, well, listen to the proper pidgin. Then you'll do the translation to English.
No matter how tall okra they grow, it no go grow passing owner.
Okay. And the English version?
That's what we want to hear from you. What do you think the English version would be? Okay, then no matter is English.
Yeah, so what I was wondering is I think what I heard was that the okra cannot grow higher than the owner, the person who planted the okra. Which is interesting, because what we're trying to suggest is your ceiling is your owner. So, which is interesting in itself. Yeah. I don't know whether that was...
Your ceiling is your owner. So what do you think they're saying, the Nigerians, with this? What's the message here?
I don't know whether it's a message. So, culturally, we tend to want our youngs to, when we have kids, want them to get to not get bigger in terms of things like respect and other things past your parents. You have to know that the point is the parents. And I don't know whether that's what they're suggesting, because I think it's cultural. So is it the question of, even if you go to PhD, your mom is still your mom, and your mom is still the point of...
Actually, forget PhD, you even get 3 of them.
Yes.
In fact, even become president, it doesn't matter.
Yeah.
Be whatever you may be, you will always have to,
even become pope, it doesn't matter.
There you go. I mean, my mom, I'm sure, she's listening, I think, and yeah, she knows. She still wields the power.
Even if you're chairman of 10 society,
it doesn't matter. It don't matter. It don't matter. There's a bill. Is it before Parliament yet, or is it still in draft stage? But it's been published.
It's been published. It's being discussed. But prior to that, I think it's important to set the stage.
Yes.
And setting the stage here is. A lot of times it's not very clear what a pharmacist does. And the assumption sometimes is the pharmacist is a dispenser, counts the pills by 5 and gives you the pills. I think that's one of the functions that a pharmacist does. But there are many other functions a pharmacist does. Pharmacists are involved they're pretty much the safety plug. A lot of times, all of us, when you have a headache, you'll go to the pharmacy. So that's an entry point to the healthcare system, not just in Kenya, everywhere you go. They'll go to the pharmacy. Some of the things we've seen over the counter, are things you don't want to remember. So they will guide you based on the knowledge, exposure that they have to where you need to enter into the healthcare system. When you go through the healthcare system, and at the end of it, the last person you see before you start care is a pharmacist. Even if it's in the hospital. And that is why in some other jurisdictions, the final say before a patient gets a medication is the pharmacist, because he's a drug expert. So you'll find in other jurisdictions, they have gotten to a point where even the physicians will rely heavily on the knowledge that the pharmacist has. Because not only does they know about the drugs, they understand the receptors, what the receptors do, what the interactions are. If you don't have this drug, which other drug can you use? Interchangeable, which drugs are interacting themselves, which drugs are interacting with food, which drugs are interacting with your condition. So there's a lot of knowledge that the pharmacist has. And a lot of times we have reduced that to give me my pills over the counter and I want to go.
Yeah.
My professor used to say, dose is the poison, which means any drug you take can be a poison. If you don't use it correctly, first of all, you will not get the relief you're looking for. Secondly, it could harm you, and sometimes that harm is long term. Perfect example, if you drink a lot of alcohol and use a lot of paracetamol, both of them go through the liver. And what you're just doing, you're taxing your liver. In the United States, acetaminophen, which is paracetamol, and alcohol interchange year after year as the leading cause of liver failure.
Wow.
So the use of paracetamol is equivalent to the use of alcohol in terms of causing liver failure. That's a simple thing that people don't even understand. When you have a headache, you've been drinking all night, you have a hangover, you pop paracetamol. Well, should you? No, you shouldn't. A pharmacist who has the knowledge will tell you, do not do that. Use something else if you need to use something.
Can I come in here?
Sure, please.
We talk about, the role of a pharmacist being reduced to giving my pills. But unfortunately, that is what has been presented to the general population.
Correct.
If it had been presented in a manner that if you go into a medical facility, for example, you go to triage where they do the preliminaries, and then you go see the doctor. If you must then go to the lab or whatever after that, and then you come back to the doctor, they tell you this is what we found or not found in your labs, and this is the medication then I would prescribe. You go to the pharmacy to sit in sometimes a god-awful line, and they come and say, oh yes, here you are, take this twice a day. That is it.
Before or after meals?
Before or after meals with lots of water.
Yes.
That's it. There's no offer of any kind of other information. The poor lad or lady is trying to get through that line.
Correct.
There's no offering of other information. You only know more about what you know about a pharmacy if you've had another kind of intimate interaction with them. But apart from that, it is exactly that has been presented to us.
Correct.
Medicine, counter, take it, go. If I feel bad, and on the medicine itself, which the pharmacist has given to you, they say, if you still feel whatever, they don't say come back and see the pharmacist. They say see who?
See your
The
doctor.
doctor.
Yes. So and and I wonder how that came to be, because when you come and talk to a pharmacist, like for example, if you come to me, I'll tell you what my practice is. When I used to be on the counter, I would start by asking you, what did you discuss with your doctor? What was your condition originally? What did you discuss with your doctor? By just those two questions, I can gauge what is your educational level. Are you a healthcare professional? Did you understand what you went to the doctor to? And did the doctor get what you were saying? So if you tell me you had a headache issue related, and then the medication that I'm seeing here are stomach related, I'm like, okay, there's something here, something that's not right. So then the next step we go to is, what did he tell you about these medications? And what do you expect from the medications? Now, this you're gauging to understand the interaction. What was the interaction with the physician? Was it holistic? Did the patient understand, I came with this and I left with this? If not, it is my duty to first of all understand what the condition was. Is the medication appropriate? Is the dose appropriate? Is it gender appropriate? Are they breastfeeding and they shouldn't have this medication? Those are questions I need to figure out. What type of foods do you eat? Are they going to interact? There are some medications that will be affected by just the eating of aspirin, eating of spinach. I mean, there's a drug, it's called warfarin. It's used for thinning blood. If you eat spinach, you've just countered it completely.
Right.
So there's a way to discuss these things. So you need to understand who the patient is before you offer it.
So you're asking how we ended up here. So how did we end up here?
I think it's commercialization of just the whole function of pharmacists. I mean, the first thing you ask me is, where do I have a pharmacy? The assumption is a pharmacist will always have a pharmacist. So what has been taken away is the commercial part is there, because a pharmacy is money making, is a shop pretty much. You've taken out the function behind it, the making of the sausage. The thing that is most important is what has been not accentuated. And
by who? By pharmacists?
I think it's I think it's a common thing. It's pharmacists. I think it is patients. I think it is a community in general. We have not we as pharmacists have not done a good job to educate others what we do.
But then, have you done a good job in interacting with your fellow healthcare providers and professionals? Because I see this as a systemic problem. You see, when I'm coming from the doctor, I'm not coming from the doctor with a doctor's report. I'm coming from the doctor with a sheet that's been written. 3 things. And those are the 3 things that I'm expecting you'll be able to read and give me. Right? So those things of you interrogating me again,
Yes.
I spent time being interrogated by that guy.
Yes.
I will not take kindly to that. So the system, if the system understood what you're saying, then the system should have had a way of you interacting with the physician by the time before I get to you, or I come to you with a concrete and comprehensive message from the physician that helps you understand all those things that you're asking.
That's very true.
So why does the system not do that then?
I think it's one of those things that has just grown on itself. It's just one of those things that became itself. It just created a monster on the side. The thing about, you talked about the interrogation, and I agree with what you totally. You don't want to go through this again. The amount of wrong medications that I've actually been able to identify by just having a conversation with the patient is amazing. Literally, where I call back the doctor, I said, you didn't get what this guy was trying to say. And it depends, and that camaraderie is very important. I used to practice in a different jurisdiction where we used to do that. And one of the things I did before I came back home was I used to just get a note that says, here's a patient, this is the age, they have this condition, what is the best care we can give? Treatment. And I would do something called a pharmacogenetic test, which is a genetic testing to see what drug fits you well. Because there are some drugs that don't fit you. And then I would propose a dose, and 99% of the time, it was the dose that was done. Then I was also involved and also managed the safety of the patient, because I'm most accessible. So I'd monitor both the dosing, whatever I give, and monitor, are they safe? Are they doing it correctly? What is the lifestyle around the medication?
That sounds more like a policy and practice issue.
It is.
Maybe even a legal issue, where it's a policy that then this is what the physician will pass on to the pharmacist or to the next people. Even if you're sending me to the lab, you're not just saying test damu. You're also telling the radiologist, I'm sending this guy to come and get an X-ray, a CT scan, an MRI because of the ABCD.
Correct.
So look out for.
Correct.
So is it a policy issue then? Is it that there's something that has not told our doctors and clinicians to do this?
And yes and no. I'll say this, where the jurisdiction where I used to work, both the pharmacist and the physicians went to school at the same time. They worked together. So even when we were doing rounds, they understood what your value was. They knew you'd save them, and they knew you'd work together back and forth.
Back.
Correct. So it's a team. And I'm gonna refocus on something a little different. The aviation industry has a near 0% error rate. What is the error rate for medications in, let's say, the US, which is what you can find online? It's between 5 and 10%.
Why?
Well,
Medications that are
error
wrong.
rate.
Yes.
Hey,
Okay? Diagnosis rate
what does that mean?
means you got the wrong medication for the wrong thing. Or you got the wrong medication, you have a different, so the diagnosis and the drug you got do not match, or your lifestyle and the drug you got doesn't match, or it's just the wrong medication, inappropriate care.
So it's wrong. Is it wrong prescription
Could be wrong prescription.
or wrong diagnosis?
So we're coming to diagnosis. This is just drugs.
Okay.
So if you look at the other things, and this is actually published information, if you look at diagnostic problems, we're talking about 5 to 15% error rate. And I would suggest that I think our numbers, we don't have real numbers here in Kenya.
Higher.
I think would probably be higher than that. But think about it. If you had a 1% error rate in flights, in aviation, what would happen? If one out of every, let's put it 0.1%, one out of every 1,000 flights goes down, what would happen? There would be an outcry.
Yeah.
Because it's a group of people who've been harmed at the same time.
Yeah.
We get harmed one by one,
Individually.
separately, individually, separate places. And we don't have that, there's no that visual of 1,000 people today in Nairobi just got the wrong meds and they got injured. Come again to the cost of care. When you're an alcoholic, and I didn't get that, and I give you paracetamol, and you damage your liver, the healthcare system has to pay for that liver damage. Or kidneys.
Yeah.
We have to pay for dialysis. That is a cost actually attributed to the paracetamol because it was not given correctly, so it has led to other costs. So then now the inequities and the inefficiencies of the system are being accentuated by not involving the pharmacist. Aviation industry was able to do what they do because people act at the top of their license. What have you learned? What part are you playing in this plane? And do the best you can. We don't do that in healthcare. We tend to cross. So
Why?
Looking at cross purposes.
I think this is an old age problem. I think it goes back to even availability. There was a time we didn't have enough pharmacists in Kenya, for example. We had very few pharmacists in Kenya. So there was a lot of, and then stuck. So
doctors are playing the entire role from end to end.
Correct.
I know they're having a problem seeding.
Correct.
Some of that. City, I know you have several questions. Go. Question number one.
I do. You see, beyond a pharmacy, having a pharmacy, or as we call them, chemistry. Chemist. Yeah, I know. It's not a chemistry. Why is it then that pharmacists don't have a practice similar to what doctors have? I'm going to explain what I mean. You see, when I come to a pharmacy, it's the experience I have when I go to a shop.
Correct.
It is very, very different from if I enter an office or a room and I'm having a discussion with somebody about my drugs. So I'm asking that simple question. Why is it?
It's a dispensing chemist.
Yes, because you see, before I get my medication, should there not be a place where, not on the counter, because we are 1,000 of us, should I not have a conversation and say the same thing you're saying, that this is why I'm here, because of this and this and this and this and this, so that my prescription is verified and I'm given the advice that I need, and I'm given the way forward. For instance, someone who is in the same profession as you sat in this very chair that you said, no, it was the same place. The chair was different. And he said many things which are very similar to what you're saying. Now, some of us who live with non-communicable diseases, you often wonder how you can rid yourself of all the medication you're supposed to take for life. Okay? And I doubt very much if my doctor, my cardiologist is a wonderful man who does a wonderful job, and he is a very open-minded fellow. So some of the things I'm saying arise from the discussions I've had with him regarding your profession. So why is it that we don't hear the voice of pharmacists? Because at the end of the day, it is your practice that advises me to take what I take.
Yes.
And for as often as I take. Yes.
Let's start actually with how many pharmacists do we have in Kenya?
So it's about, the number is fluid because there are some who've left the country. So it's about 4,000 who have been trained, and a good number of them don't have jobs right now. And they are not offering the service. I think what you just said, Siti, is so true. The value of what a pharmacist brings to the healthcare system has not been highlighted correctly, has not been brought to the forefront. And I think part of the reason, and that's why we're going to pivot to the KDA bill, which we support as pharmacists, because it's bringing standards back. We're trying to get standards. The KDA divides the product from the practice, in which case you don't have the products or the commodities, which say HPTs, pulling back the profession, or the profession pulling back the HPTs. They go separately and they grow according to their needs of the various things. And I think that is a key part. Anybody, and this is now almost a declaration, anybody who enters a healthcare system, including your dog, has to go through a pharmacy or use a pharmacy-related product to move from why they got into the care to when they get well. And the drug, whether it is just for testing, whether it's actually a drug that you're going to take home, whether it is an NCD, you have to use those drugs. And who's a drug expert? And I introduce myself as a drug dealer more often than not, because that's all we do. We deal, we study, we learn, we are exposed to drugs and how drugs work. Why then is it that value is not brought in? In the US, they say the economic impact of wrong medications, not wrong medications, between 20 and 40 billion a year. The impact, economic impact. Dollars. If you do some quick math, Kenya will then be around $4 to $5 billion in terms of what? Economic impact of wrong medications. That is almost the same amount what we use in all healthcare. Does it mean if we manage our meds correctly in this country, we will have economic output enough to provide healthcare for free without increasing taxes? And that is what the enormity of using the drug correctly is. It's so important that even when you go to the pharmacist, you're tired, please ask the questions. Ask questions, enough questions, to understand that what you're carrying, what it's going to do, what are the side effects. If the side effects come, what do you do with those side effects? What shouldn't you eat? What time should you take it? How should you take it? Those are details. And a good pharmacist will do that very quickly and give you the information. The idea is you make sure it's 4th grade level so that anybody, and that's why I used to ask the question to gauge the words you're using to tell me I shouldn't give you 4th grade, maybe I should give you 12th grade knowledge to how to deal with that.
So should you have a pharmacist after the doctor before you go to the dispensing place?
Yes, actually, one of the things we were talking about at PSK is having a family pharmacist, just like you have a family physician, a person who understands all the meds you're taking, how you're taking them. If you want something over the counter, does it interact with the current NCD medications? And that's the next thing, actually.
We don't have family physicians.
I'm not even talking about the one you go to see on a Saturday morning.
Correct.
I'm talking about in the clinic,
yes,
in the hospital. Should you not, when you leave the doctor who said these are the lab results, before you go to the counter where they dispense, because if a prescription has been written and I know what's in the thing, anybody can dispense.
Yes, that's true.
But from what you're saying now, shouldn't you then go see a pharmacist before you go to the dispensing counter?
So I would suggest, and not because I'm a pharmacist, that would save the healthcare system a lot. Because then you don't take things away that you should not be taking. The number of people who are on dialysis in this country, the number of people who have liver failure in this country, yes, alcohol is an issue, but the medications that are a part of that. The number of medications that are being given that are actually interacting with other medications you're taking, the harm, the deaths that have come because of those things, they are there. We don't keep very good records of that, and we're going to move that. We're going to move towards that. Part of the reason why KDA is a very good bill is that it raises those standards. It raises the standards, makes sure that the competencies and the technical competencies of whoever is participating is right. And the bill has a lot of reference to WHO standards, which you talk about personnel, talks about training, talks about who should do what. And it's very important. I personally think, and this is my personal opinion, that the KDA bill is a patriotic bill. And you'll ask why. Because if we put the pharma industry where it should be, it will create jobs. We'll be able to sell, because then the competencies of what we are selling out, the pharma, the foreign currency that will come in from us selling medications would increase. But we have to make sure we don't shoot ourselves in the foot. We have to make sure that we have the right technical people doing the right technical things. Just like what, when you come from a physician, you see a pharmacist who guides you, then whoever dispense can dispense. Could be another pharmacist dispensing, but now it's gone through the check that is necessary. I will bet you the amount, they say, it's expensive to hire a pharmacist. The amount of what we'll save as a country, the pain and everything else, would be enormous.
Where do farm techs fit in all this?
So, it's It's political.
Those are
a little
two
bit.
very huge
There are
sides.
two. There are two issues here. Remember, I alluded earlier on that the number of pharmacists we were educating, training, was a little less than what the market needed.
Yeah.
Yes.
So then the whole history of why technicians were the clinical officers, technicians. That's a whole history, a geopolitical issue why it started and where it started. As a result of not being we did not think through the whole thing, how it's going to end. We didn't think about the end in sight. And as a result now, we've come to a place where technologists actually do 3 years of school. Pharmacists do 6. So there's a gap there of 3 years. And that 3 years is what I was talking about, exposure. I talked about the knowledge base. And when you have a knowledge base and the exposure, then even calling an audible, changing something, you understand what you're changing. And that wealth of information translates into safety on the patient side.
But do they have the basic?
They do.
They do have the basic.
Correct.
And the basic here, would that basic go to the extent of sitting down with the patient? If we said that we go this route and say, from the doctor or clinician, you will go through somebody who understands pharmacy. Can that person be a pharm tech?
So I personally would say no. I personally would
Why?
suggest, because just what I just said, the knowledge
Because of
base, the exposure,
Okay.
the knowledge base, because 3 years extra of school,
where would you
Listen.
place a pharm tech in this chain?
I think they're dispensing. Dispensing is an excellent place. And then if you look at the international standards, and you see, and that's why the KDA bill is alluding to the WHO standards a lot and international standards, is exactly what I'm saying. The international standards, I remember one of the jurisdictions I used to work at, the technician who was there could not even put medication in a bag.
Why?
Because my license was on the line and I wanted to make sure that all the meds that go into that bag belong to that patient. And if they don't and they go harm that patient or the wrong medications, it's me. So I only, if I trusted you enough, I could allow you to do it. But I would put all my medications in the bag myself. So
Because it's you who has the license.
it's me, it's me who has the license.
Let me ask this question differently. You look at the different cadres of healthcare professionals. Okay, we're referring to the pharm tech. I'm looking at clinicians and I'm looking at nurses. Different cadre. Not lower, not higher, just a different cadre. I'm looking at clinical officers. Different. And many others. Now, for these cadres to exist, there must be a good reason. There's a role they're supposed to play. So what is the role of the pharm tech?
So I don't know whether I can answer that really well, because there was when the whole pharm tech of now pharmacy technologists was when that role was initially developed. What was behind the thought process, I cannot allude to because I don't understand.
Can I assist you?
Yes.
Because if I look at how we categorize our healthcare system, it's in levels.
Yes.
So you will find a certain healthcare professional at a certain level.
Yeah.
And until you get to a point where at that health facility, you then get to a doctor. You'll get a nurse, you'll get a clinical officer. Then at a certain level, you get to a doctor. Okay? And with a doctor comes facilities. You have a lab. And then you have a certain category of lab as you keep moving up. So I am taking the view that it was with that same thinking that the position of the lab tech was...
Okay, Yes. I'm also seeing something maybe, and
Yes.
you could correct me. The entry-level requirement academically, right? So at a certain point in time, everybody who was getting the A's wanted to be doctor. And then they want to proceed on to become whatever, the cardiologist and everything else.
Yes.
And not many wanted to do pharmacy.
Yes.
And now we have a shortage of pharmacists. And those that are qualifying for this particular profession are not preferring to go into pharmacy. But we must have people who are doing this job. So you go into a lower entry level requirement, and now you take it to diploma level, and you have the farm techs
You know,
coming in and playing a certain role in this value chain.
Eric, you know,
How far am I from the truth?
I don't know what's happening now,
Eh.
but you've taken my mind back to when we joined university. Pharmacists and doctors had similar qualifications.
Yes.
It was not, you could be either.
Yes.
It wasn't that you did. It was,
That's what I'm saying.
yes.
It was the A. For you to be a pharmacy, you've got to score
Yes,
A.
you had to.
But then, those that are scoring A's are not choosing
Pharmacy.
pharmacy.
Oh, no, actually, it's interesting that you say that.
Is that
right
not-
now we have a glut. We have more
Now more
pharmacists
and
than we
more.
can- we have
Now more and more
pharmacists.
choosing.
Yes, we have more pharmacists than we have spots for them.
Yeah.
That's one. Number two is the same issue that we have with clinical officers and physicians. Same conditions. When we started, pharmacy was being taught in one school, which is University of Nairobi, and they used to take about 20 to 30 people, right? That does not that is not going to be enough
Yeah.
for a country like ours.
Yeah.
And that is and the thing is, so then as a result, it will now reduced to dispensing, because that's what you can do quickly. Okay. And I stand to be corrected on that, but that's just logically. However, when we got to where we are right now, cost of care the way it is, unless we address the way we use our medications, we are not going to cut it. Because think about what we're having about the antibiotic resistance. We're having patients who are actually losing their lives because they're using the wrong medications.
Yeah.
We are coming to cancer, that there's very toxic medications. When you're a patient receiving chemotherapy, this is another function for a pharmacist. When you go home, your family and loved ones have to handle you in a particular way. Your fecal matter, your urine, all those things, your saliva sometimes is actually toxic. But we don't know how to deal that. And that's a pharmacist's job who should come in and say, here is what you can do here. And that is for safety for the public.
Yeah.
So when we have a pharmacist really installed properly to work the top of their license,
Yeah.
it's just like the aviation field. If you get them to understand drugs, and they understand the drugs, to be able to explain how drugs should be used, safest way possible, we change how healthcare works and we reduce the cost in healthcare.
So if understanding this whole, and I think it's an end-to-end thing, understanding all of this, then we also then want to ask then who bears the responsibility to ensuring that that particular peg is placed in this process? Who should? Because I don't think doctors necessarily want to moonlight as pharmacists. You know, they do their job in diagnosis.
Correct.
That's why they hand it over to somebody else. But I think here we're also saying that there's a certain level of, I don't even know if it's understanding or it's just like, look, I've done my part until here. Let somebody else take over, right? But it needs to be an inclusive thing.
Correct.
That is what we are saying.
Correct.
So who's responsible? I don't see pharmacists coming in and, you know, poking themselves and say, you must include me. So it seems almost as though it must be an invitation of necessity.
Yes, and there's a few places. I'm just going to, there are many, but I'm just going to name one. Moi Refaro, there's Dr. Keegan there, who's been able to set up a very good system where there are some cases, actually there's even a pharmacist in Kembu, there are some cases the doctors will not round without that pharmacist being there. Without the pharmacist input, they will not move because the pharmacist will come and do, will do the drug part.
Because the doctor has insisted.
Because the doctor has actually understood the value.
Right, okay.
So the thing is, they've gotten exposed to the value, and once they get to understand, wait a minute, you can do all this, then now they don't want to do work without you because you're making it much better for them. It's much easier, it's much safer for the patient, and the patients are getting better sooner because you're giving them options of how, because we have a supply chain issue. So we can also, the options of what can actually, if we don't have this drug, how do we use this? Just the other day I was actually rounding somewhere with some doctors, and they didn't have a pharmacist on board. And one of the things they said was, sometimes I write a drug and I don't even know whether the patient got it. I was like, And then they also went ahead and told me, sometimes I will actually dose a medication. I don't even know how to dose it, and I can't find a pharmacist because we don't have a pharmacist to dose it. So I dose it as best I can. I have a friend who lost her hearing because there are some medications that if you don't monitor properly, you either lose your hearing or they call them aminoglycosides. You either lose your hearing or your kidneys. And the fact that it wasn't monitored, they lost their hearing.
Wow.
That's pretty extreme.
Oh,
Wow.
Well,
But also, I'm not saying. I'm sorry. I'm not saying that it's extreme that don't bring it in. I'm saying that it is so extreme not to want to have this inclusivity that we speak of for then pharmacists.
Yes, and I think the issue is also now. The issue here now comes, which is a thing that we have to really think about as a country too. It's delayed gratification. Sometimes we talk about how much do we pay now. What you pay now is already paid. But what is the investment you've just done? If you pay a pharmacist 200,000 and they save somebody's life down the line, or they save the healthcare system, the way it's using its products, right? That is a community benefit that sometimes we don't look at. We look at how much are we paying somebody now? What is coming out of my pocket now? And not what am I investing in terms of the benefits that will come down the line. And I think this is the thing we have to really think seriously about. I have dealt with patients' records that I look at and I cringe. I cringe at how bad they are. And it's reality, it's there.
I look at regulation of our healthcare system. So you are regulated by the Pharmacy and Poisons Board presently, right? Which is now going to be the Kenya Drugs Authority if it passes through Parliament. That is separate from who is regulating the doctors and hospitals. Even to operate a hospital, it's the KMPDC that will allow the hospital to run. But within that hospital, if there's a pharmacy, it's a Pharmacy and Poisons Board
Correct.
that will allow the pharmacy to run in the hospital.
Correct.
And then you've got nurses who have the nursing council.
Correct.
And everybody's just being regulated by everybody else.
Correct.
And it appears like these bodies are ending up not talking together, despite even the establishment and the existence of the Kenya Health Professions Oversight Authority. What does it do, and how does it bring that conversation together? And then you as healthcare professionals have also come together in the various associations, Pharmacy Association, Doctors Association, Nurses. You also have the Healthcare Federation, where you all come together. It appears you have opportunities to say the same thing, but you don't. Why?
Interesting. I don't know whether I have the age or to answer that, because by the way, the issue of having different...
As CEO
Yes.
of the Pharmaceutical Society of Kenya, you represented your people.
Correct, yes.
In the Kenya Healthcare Federation.
Yes, I did.
All right?
Yes.
Why are you taking these concerns to the Kenya Healthcare Federation to say, all right, people, can we think of how we can reorganize this system so that we all are serving this patient end to end?
We had several conversations, and the conversations sometimes were as a result of quote-unquote encroachment, where somebody came and did something in another area's jurisdiction, blah, blah. But you see, international standards is the same way. I mean, if you go to other places, the UK, the US, the pharmacists are run by pharmacy board somewhere, and then the nurses on their own, because of the speciality of what they're doing.
Okay.
But I think one of the things why it works better there and why they actually include, I know that in the US, it was liability. There's something called standard of care. So when a patient passes away in a hospital, they say, okay, what did they come in with? This and that. What is the standard of care? The standard of care includes consulting a pharmacist on medications that you gave. So that the liability folks will look and say, did you do that? No. Then you're automatically liable, whatever the case might be. If you follow the standard of care, then now we can discuss and see maybe mistakes happen. But the key thing was standard of care, which is something that maybe we need to really drill down and try and see how to build it here, such that anybody who goes in, especially now that we're going to start dealing with more NCDs.
Are we saying we don't have it?
I am not saying we don't have it. I'm not saying
Okay, then what do we have?
I think
What's the closest equivalent that we have to what you have experienced in the US?
there is protocols. There are a few protocols that are there that we use. We have semi-standards of care. What I'm saying is we need to beef them up. They are there. They need to be beefed up enough to make sure they have teeth.
By who?
by the various bodies. I mean, the regulatory body like PPP, all these are bodies that are actually working on a lot of things. There's a lot that's being done.
Does
right
the
now
Health
to work
Act
on that.
cover this?
Yes, it does.
And what about the enforcement of some of these regulations?
And that's where I was going to go and say the enforcement, the budgets, there's a lot more that goes into some of these things. And I think as a people, we need to now request that we need, not request, maybe ask that we need these things taken care of.
You know, Dr. Let's step back, okay?
Yes.
You know what I was saying?
Yes.
The A's end up in being a doctor, being a pharmacy, and all these things. The brain trust of this country is what is running the healthcare system. It is what is designing the policies of the healthcare system. It's what is advising on the laws of the healthcare system. The enforcers are healthcare professionals. So when we hear healthcare professionals saying there are gaps, there are problems here and there, I sit back and wonder, so who's going to solve this problem? I mean, who else is going to do it? And that's why I brought to you and said, you have sat at the CEO of the association representing pharmacists. You have represented them in very many other meetings. All right?
Yes.
Have you taken these concerns to your fellow healthcare professionals? And have you had a conversation? Are healthcare professionals having these conversations that will benefit all of us, you guys included?
Yes, they're having those conversations. And I think one of the things that I'm going to mention, Eric, is that the UHC, the requirement for UHC now, the need to us get there, I think it's an excellent opportunity for us to align all these things. Because when you align it, then you reduce the costs. You're able to actually you're able to monitor, because now you have a target, which is UHC. Currently, the way we are, we need to do a lot of changes for us to be able to make there. Because especially, and I'll say one change, drugs need to be run by pharmacists. They need to understand what patients are getting, why, when, how. That needs to be them running it, period. Because if you don't, you lose.
Do doctors agree?
Do doctors agree?
Do doctors agree?
They are, good number of them do agree. Good number of them agree.
Those that don't agree, what's their
problem?
It's a territorial thing, I think.
What's their concern? It's a territorial
I
what?
think it's a habit. When this is what we used to do.
It's culture.
A culture. What do we now? We are here. Why do we want to change? Now, remember some of them when it started doing medicine, they had maybe 100 meds. Now there are thousands
And
coming
remember,
in.
the industry that produces the very products that we talk about and which you're supposed to superintend, when they do their marketing, they go to doctors.
They go to doctors.
Yes, they go to doctors.
Yeah.
So now,
So is there some commercial element to this?
commerce runs.
There's commercial benefit that they would lose.
I don't know about losing, but I'm just saying there's some commercial. What are they saying? Nods that have to be.
Well, there must be, Dr. Isn't it? Because pharma go to doctors in terms of marketing,
Yes.
hoping that they will prescribe their medication.
Correct.
They're not considering the pharmacology of all of it.
Correct.
They're
And-
saying, prescribe our
thing
medicine
is good.
so that we can buy. People can buy.
And that's the world over.
And actually, yes. And I think I want to bring something else here. There's something called precision medicine that has been coming out. The meds we have, in our industry, when you say what I'm saying was written in the New England Journal of Medicine, everyone says, Question is, New England Journal of Medicine does not have people like us. So the studies that are there are not for people like us. They don't eat ndoma in the morning, and they don't eat uji, and the food
And my
lifestyle
choma.
is totally different, right? So the medications, the dosing that is suggested for them may not be appropriate for us. So that's why precision medicine is coming in, genetics. How do we make sure we get genetic information for our patients to understand what our patients are taking? This is going to be very important, especially with NCDs. What diabetes medication works best for Africans, and how do we make sure the dose is right?
Yeah.
Things like those.
You need to come back.
Yeah.
I'm happy to.
This
Yes.
discussion has just begun.
Oh, yes. And we are glad that you joined us today.
I'm happy to.
Dr. Lucas Nyabero is a pharmacist. He is a former CEO of the Pharmaceutical Society of Kenya. He has introduced himself as a drug dealer, the legal kind.
This is The Situation Room the only way to start your day.